A very good evening and a warm welcome to one and all present here in this session. I am Debolina from Clearnet. We are very much proud to be a part of this webinar as a digital partner. As you all know, Clearnet is India's largest live digital CME and doctors generated medical content platform. So now with all of you, I am going to share a short glimpse of Clearnet. Thank you so much, all the doctors, for your patience. Our website is www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors only, that also you can read. Besides, we have polls and quiz also on our platform that you can read in your leisure time. So you all are invited to visit our website. I will again repeat www.clearnet.com. So now, without further delay, I'd like to hand over the session to Dr. Riddhi Shukla ma'am to proceed from here. Over to you, ma'am.
Yeah, ma'am. Dr. Susil, please start.
Good evening to all. I welcome you all to IMS Presidential webinar series. Today's seminar is, as you all know, it's about topic of urogynecology, organized by Urogynecology Committee of IMS and IMS Education Committee, hosted by Vijayawada OBGY Society. Once again, I welcome you all. I welcome Dr. Lakshmi Shikhande, my dear friend, lovely human being, and today as a chairperson of IMS Education Committee, and Dr. Manoj sir, IMS Urogynec Committee, to introduce our esteemed guest and welcome all the senior members, Dr. Hara Patnaik sir, Dr. Madam Shobna Mohan Das ji, Dr. Anju Soni, all our speakers and panelists. Over to you, Dr. Lakshmi.
Yeah, thank you so much, Riddhi. And I'm so happy to be part of this IMS Presidential Webinar Series, which is a brainchild of our National President of Indian Menopause Society, Dr. Shobna Mohandas. I don't know how she is finding time and energy, but she is very, very consistent in doing this webinar series, and her idea is to cover all the topics related to the women's perimenopausal and menopausal health. So thank you, Dr. Shobna, for giving us this chance, because Manoj as chairperson of Urogynec committee and myself as chairperson of education committee, we have joined hands for this webinar. And here we are having two lectures on voiding dysfunction, painful bladder syndrome, and the panel will be moderated by none other than our IMS President, Dr. Shobna Mohandas, on recurrent UTI. So as you can see, all the three topics are very useful in our day-to-day practice. So on behalf of Manoj, because I can't see him, I would like to welcome IMS President, Dr. Shobna, IMS General Secretary, Dr. Anju Soni, today's chief guest. Now I can see Dr. Hara Patnaik, all the esteemed faculties, and of course the President and Secretary of Vijayawada Society, and all the office bearers of Vijayawada Society. So thank you once again for giving us this opportunity, Dr. Shobna, to be part of this prestigious webinar. Riddhi, will you be introducing chief guest? Yeah, I can see Dr. Hara is here. Unmute karo.
Thank you, Lakshmi, for coming in the middle of all your busy schedule. Every day you're organizing something.
You are doing wonderful work, Dr. Shobna.
You also.
Lakshmi, you can introduce Patnaik sir.
Yeah. It's a pleasure to introduce Dr. Hara Patnaik, a great human being and a great academician, and I am sure he has given only 2 lines. Dr. Hara, his biodata is very, very vast, but you don't need any introduction. We all know. And in Indian Menopause Society, everyone knows your work, which you have done in the capacity of president of IMS when you were president. So we welcome you for this webinar as guest of honor and invite you for sharing your pearls of wisdom. Dr. Hara, please.
Namaskar. Thank you, Dr. Lakshmi, for those kind words. And Madam President, Dr. Sobhna Mohandas. And it's a pleasure again meeting in a virtual platform with the dynamic secretary, Madam Dr. Anju Soni, Dr. Bipasa Sen, Dr. Jyoti Jaiswal, and I'm not able to see Dr. Manoj, but Dr. Riddhi, Dr. Gayatri, and dear Tanveer, the today's speaker. I'm really proud of you. Madam Sobhna, actually, after the tenure of president was over, actually, I was given an additional extension of becoming chairperson of Urogynecology Committee in Bangalore conference in 2020, when Jignesh was the president, and I was to serve as the chairperson of the committee for 2 years with Dr. Jignesh Shah and Dr. Ambuja, which I have already completed, and I feel really very happy and proud to hand over the doyen to the ever charming, ever dynamic Dr. Manoj Chelani, who in fact was doing all the Urogynec WhatsApp and program during my tenure for the last 2 years very nicely and very successfully. And today he has started doing the WhatsApp as the chairperson. I wish all the good luck to him. And first of all, I must wish pay my regards to Madam Rama Devi and the great gynecologist of Vijayawada and the entire team of Vijayawada, which I visited few years back. And second thing is that Madam Sobhna, you have done a very nicely framed, structured program for IMS in different chapters this time. And I love to hear it again and again. And second thing is that today Dr. Tanveer will be speaking to us, and I feel very, very happy. And she has made a mark herself, and I feel happy to see you in different operating workshop and different conferences. I hope I will be there always to be with you all and enjoy the academic and all the other programs, whatever, whether it is a dancercise or exercise or academic or Club 35 Plus. With these words, I pay my regards to the president and entire team of IMS 2022 and the team of Vijayawada by Madam Ramadevi and her team and Dr. Manoj Chelani and her team. Thank you very much, Madam Lakshmi, again for those kind words. Thank you very much.
Inviting now our convener, Madam, respected R.S. Ramadevi Madam and Dr. M. Shailaja. Madam, you can have two blessings before we start our first guest speaker. Over to Madam R.S. Ramadevi.
Hello, madam, are you there?
Hello,
Yes.
I'm here. The video is not there. Video is not there. Okay.
Yeah.
Video disabled, it seems.
Ma'am, I have sent you a request. You can start your video.
Good evening to all of you. Am I audible to you?
Yeah.
Okay. Dr. Hara Patnaik, past president of IMS, Dr. Sobhna Mohandas, present president of IMS, Dr. Anju Soni, secretary general, IMS, and the chairpersons. Along with me, Dr. Shailaja, and conveners and coordinators, Dr. Manoj Chelani, Dr. Lakshmi Srikande. On behalf of Vijayawada Society, I thank the organizers for giving us the opportunity to be associated with you. And very good evening to all of you, and especially Dr. Manoj Chelani, Chairperson IMS Urogynecology Committee, Dr. Lakshmi Srikande, Chairperson IMS Education Committee. Thank you very much for this And now Dr. Gayatri is going to talk on voiding dysfunction, very important topic, and she is very thorough with this urological problems and physiology, the urogenic department, and she is working with all the problems of the urogenic department in Vijayawada, in Pinnamneni Siddhartha Medical College. So, shall we? I request her to start her lecture. And it's a very important online. Still, you are continuing online. We are very happy. And not the physical meeting. So at least some of the meetings may be physical. Still, we can continue because still Corona is continuing. Still, that is a problem, and other problems also are coming. So now I request Dr. Gayatri to proceed with her topic.
Hi, I'm Gayatri. I thank the IMS Society and the Work Society for giving me this opportunity. Can I share my screen?
Yes, ma'am, you can share your screen.
Visible, Debilina?
Ma'am, screen is visible. You need to make it a full screen.
Is it full screen?
No, ma'am. Currently,
Yeah,
I guess we can't see the screen.
visible now?
Ma'am, full screen is not visible. Like a PPT, we can see.
Full screen, but I'm not able to. I'm able to. I'm pressing the resume share. It's coming as the PPT presentation.
Okay, ma'am. Then you can do one thing. You can stop the sharing and share your entire screen. Maybe that will help you.
Debolina, do you have her PPT with you?
No, ma'am.
Then you
I don't
can
have.
start.
Ma'am, I don't have her PPT.
Can I send it now? Yes, it may take time, right?
Gayatri,
Yeah.
you can, you can just make it full screen.
Yeah, I'm making it.
Yeah, you can just click the slideshow which is above, actually just adjacent to the animation. Maybe that will help you.
A new share. This is what I need.
Otherwise, you can just continue. It is like visible.
Can I continue with the same thing?
Yeah, that's okay. You can continue.
Yeah. Thank you. Thank you, the IMS Society, for giving me this opportunity to be part of this webinar. We'll be talking about this voiding dysfunction, which is a very important thing which affects both the neurologically impaired people and menopausal, and also the postpartum problems are more common with voiding issues. So these are
Gayatri can be a little louder, ma'am.
These are various problems which are related to the ability to store or empty the urine. The problems can occur either at the bladder or at the level of the outlet, and most of the times the symptoms do not correlate with the pathology. So there are numerous conditions which have similar presentations, and it becomes a challenging task for us to treat this voiding dysfunction. So before going into the actual part, we have to know about the neurophysiology of the micturition. Actually, bladder filling and the voiding is basically an integration of both the peripheral nervous system and the central nervous system, which involves the brain, the spinal cord, along with the peripheral nerves, which are the pelvic and hypogastric and pudendal nerves. So there are M1, M2 receptors which act for the detrusor contraction, and the beta 2 adrenergic receptors which are there in the detrusor muscle helps for relaxation, and alpha adrenergic is basically present at the bladder neck and the sphincter, and stimulation of it increases the urethral tone and increases the uterine pressure. So the spinal cord transmits the afferent input to the lateral and posterior spinothalamic tract, and these converge at the level of the pontine micturition center. And from the pontine, you have got the medial and lateral regions. The stimulation of each one of them is going to either help in increasing the pelvic floor tone or decrease the pelvic floor tone and the urethral tone, and is responsible either for holding the urine or for emptying the urine. So coming down to the micturition reflex, the normal bladder distension causes stimulation of the afferent nerves, and this causes an inhibitory response at the bladder, which is efferent input is from the hypogastric, which stimulates the external urethral sphincter and which is responsible for bladder distension and the increase in the urethral tone, which prevents the bladder from emptying. Once this stimulatory response from the hypogastric is lost, that means there is an efferent input from the parasympathetic through the S2, S4 spinal cord, which is responsible for detrusor contraction, and the urethral sphincter relaxation responsible for coordinated voiding. This is mainly responsible because the treatment of voiding dysfunction basically depends upon how you manipulate either the drugs which increase the bladder tone or which relaxes the urethral sphincter tone. So the normal voiding is basically accomplished by the micturition reflex through the pontine micturition center, the sacral micturition center, the sympathetic control, and the central facilitatory area, and the inhibitory is basically from the cerebrum, the cerebellum, the basal ganglion. The voiding dysfunction is basically classified into detrusor undercontractility or detrusor acontractility and bladder outlet obstruction. The detrusor undercontractility is neurogenic or myogenic, and bladder outlet obstruction is either anatomical or functional, which includes dysfunctional voiding.
Gayatri, please be louder, Gayatri.
Yeah, I am. Detrusor sphincter dyssynergia and Fowler syndrome. So the detrusor undercontractility, according to the International Continence Society, which states that the contraction which is of reduced strength or duration resulting in the prolonged bladder emptying or failure to achieve the complete bladder emptying within a normal time span is a detrusor undercontractility. And acontractile is one which cannot be demonstrated. The contraction cannot be demonstrated during the urodynamic study. And this includes a primary or a secondary detrusor undercontractility. The primary is basically an age-related decrease, and secondary detrusor undercontractility is because of the secondary to diseases like diabetes mellitus. The pathogenesis of detrusor undercontractility can be either myogenic or neurogenic. And these are all the various reasons for the woman to have detrusor undercontractility. This can be neurogenic because of the various central nervous system and peripheral nervous system injuries, including the stroke, spinal cord injuries. Myogenic is because of the aging or acute prolonged bladder obstruction, or mixed because of the diabetes mellitus. And other reasons of neurogenic bladder detrusor undercontractility is because of the menopause, immobility, recurrent urinary tract infections, anesthesias, and postoperative drugs. So the cerebral lesions can be either spinal, sacral, or subsacral lesions. Basically, you need to know about this neurological. It is mainly managed by the neurologist.
Gayatri, are you there? We can't hear you. I'll just call her, madam.
Can somebody call her, Gayatri?
Madam, I called her, madam. Just is checking. She's checking it out.
I think she has some net issues.
Shall we go with next lecture?
Yeah, that's what we need to do because shall we start with the next lecture? Yes,
I'll just find out, madam. I'll just find out. 1 second.
Hello.
Gayatri?
Yeah, hello.
Yeah. Can you share?
Yeah. Is it visible?
Yes. Gayatri, you can continue.
Yeah. So the neurogenic lesions basically depend upon where the lesion is present. So you have got suprapontine and the pontine lesions are basically responsible for detrusor overactivity, whereas the sacral or intrasacral lesions are responsible for age contractile detrusor. So coming down to the myogenic causes, it is most probably because of the aging process. 48% of men and 12% of the women usually present with the detrusor under contractility because of the myogenic causes. They most often have a decrease in the urine flow rate, decrease in the voided volume, decreased bladder capacity. Now, the other important lesion is about the acute prolonged overdistension, which is an unrecognized medical phenomena, occurs after an extensive pelvic surgery or operations which has been done under spinal anesthesia or patient with a prolonged childbirth. And this comprises of basically 2 consecutive stages, which is a temporary neurogenic dysfunction, and the secondary or the lesion is myogenic because of unrecognized primary acute retention will lead to myogenic detrusor damage if neglected, and this becomes an irreversible damage. And we identified by the presence of the post-void residue, which is more than 150 ml. There can be a mixed myogenic and neurogenic causes due to diabetes or peripheral autonomic neuropathy, or leading to impaired bladder sensation with consequent bladder overdistension and decreased flow rates and an increased post-void residue. The reason why the diabetic people are most responsible for this bladder detrusor is because of the hyperglycemia, which causes an oxidative stress over the muscle cells and the macro and microvascular damage on the detrusor muscles and leading to undercontractility of the detrusor. And detrusor undercontractility also occurs in patients with menopause and constipation also. Menopause, it is because of the axonal degeneration and loss of the function of detrusor muscle. Constipation, which is a commonest complaint in menopause, leads to rectal distension, which reflexly inhibits the detrusor contractility. And because of the distension of the rectum, it causes a bladder outlet obstruction and due to fecal impaction. The other reasons can be because of the anesthesia, recurrent urinary tract infections, and medications like antipsychotics and anticholinergic drugs. The commonest lesion what we see is postpartum urinary retention or postoperative urinary retention, which occurs in 0.05 to 37% of people. It is described as an aching or an acheless inability to completely micturate requiring catheterization over 12 hours after giving birth, or patient is not able to void 6 hours after vaginal delivery, or patient voids only small amounts of urine and the patient has an urge to micturate but is not able to micturate, or the patient needs catheterization where she drains almost 500 ml within first 24 hours. This is classified as an overt where she is not able to micturate within 6 hours after vaginal, or a covert where a post-void residue as an accidental ultrasound diagnosis showing more than 150 ml or patient needing catheterization with no symptoms of urinary retention. It is because of physiological or because of mechanical factors or because of neurological reasons, because of the pain, which is the commonest reason for the woman to develop urinary retention in the postpartum or in the post-operative or in the antenatal period. These are all the various reasons why the woman usually develops postpartum urinary retention. Most often we see after an assisted vaginal delivery or a patient had an extended episiotomy, patient is having lot of perineal edema or an obstetric anal sphincter injury and weight of the baby more than 4 kgs. And in gynecology, because you have done laparoscopic dissection, pelvic dissection, or an IV injection or intravesicular injection of Botox, which all lead to retention of urine. We usually diagnose by doing a post-void residue on ultrasound or by calculating the post-void residue by draining by catheterization. Now, we usually manage this post retention by diagnosis by abdominal examination of the patient, giving an adequate analgesics to the woman, and intrapartum, the management includes both an antenatal, intrapartum, and post-operative management. Intrapartum patient should have a regular voiding of every 3 to 4 hours, and if she's not able to void, go for catheterization. And in the patient who is doing an active pushing and patient has an indwelling catheter, deflate the catheter and remove the catheter. Following a vaginal delivery, the catheter should be in place for 6 hours after you have given an epidural topper. And other conservative methods, what she can do to empty the bladder is by running tap water, adequate fluid intake, sitting in a squatting position to empty the bladder. And if she is not able to do that, catheterize with only 12 to 14 French catheter. If there had been a significant perineal trauma or obstetric anal sphincter injury, the catheterize should be in place for 12 to 424 hours, not more. And when you are catheterized, it depends on how much of post-void residue is present inside the bladder. If it is more than 150, but it is less than 500 ml, keep the catheter for only 24 hours. If it is more than 500, but less than 1000, 2 days of catheterization is necessary. If it is more than 1000 ml, the patient needs to be catheterized for 3 to 4 days or longer. And as we all know that whenever we are taking catheterizing the bladder, always take the sample and we send it for urine culture sensitivity. And other important thing is whenever we are doing an LSCS, the patient should be on a regional anesthesia. The catheter should be removed only after 12 hours after the last top-up dose of epidural analgesia. And once you have removed the catheter, the patient should always record the first 2 voids of the urine following the removal of catheter. And the first void should be within 4 to 6 hours, either after giving birth or after surgery, after removing the catheter following an LSCS, and encourage the woman to void after vaginal delivery or after cesarean section following 12 hours after the last top-up dose. And you are successful when you find that the voided volume is spontaneous and the patient is voiding more than 200 ml and an ultrasound is showing less than 150 ml on 2 separate occasions and patient does have a feeling of bladder sensation, then it indicates that her bladder has recovered from the neurogenic damage which has occurred because or neurogenic cause which occurred because of either extensive perineal trauma or because of the radical pelvic surgeries. Now coming down to the functional causes, which includes bladder outlet obstruction, which is most often anatomical or functional. As we all know, most of the postmenopausal women have an anatomical cause for bladder outlet obstruction, which includes patient having a pelvic organ prolapse with high grade of cystocele, or patient had a midurethral sling or a urethral strictures causing urethral inflammation or traumatic urethral injury, or a iatrogenic trauma, or it can be functional, which is dysfunctional. You have different causes in functional bladder outlet obstruction, which includes dysfunctional voiding, detrusor sphincter dyssynergia. And out of these, we know that dysfunctional voiding is an involuntary intermittent contraction of the periurethral sphincter striated muscles during the voiding in a neurologically intact individuals. And this is also a learning disorder where the patient usually occurs in women who has been in working and where the circumstances are not favorable for her to go for voiding. Whenever she has a detrusor contraction or an urge to void it, to stop that urge, the patient contracts the external urethral sphincter, and this becomes a learned behavior. Detrusor sphincter dyssynergia is a contraction of the striated urethral sphincter muscle in a neurological abnormal patients is called as detrusor sphincter dyssynergia, which you usually find in pontine lesions. So primary bladder obstruction is a different entity. It occurs in 0.5% of women, and 16% of women have an obstruction because of bladder neck obstruction. It is because of the failure of the bladder neck to open properly in presence of a detrusor contraction. The cause is unknown. Most often it is either because of the smooth muscle hypertrophy, or because of the increase in the collagen deposition, or because of the high tone in the smooth muscles of the posterior urethra causing rigidity of the bladder neck, or because of the increase in the bladder neck alpha adrenergic receptors. Initially, patient presents with storage symptoms like frequency, urgency, and urge incontinence. Later, patient starts developing avoiding symptoms, that is, patient will have difficulty in initiating hesitancy, poor stream, and failure to completely evacuate, leading to retention of urine. The other commonest thing, as a urogynecologist, we all come to know, and as a menopause specialist, most of the times, an iatrogenic cause for the outlet obstruction. Most often it is post-surgical, it is usually underdiagnosed, there is an incomplete evacuation, and because of the incomplete follow-up of these patients. It is because the patient has undergone surgery for stress urinary incontinence. It is because of the improper placement of the midurethral sling, or because of an extensive tension, or indirectly when you have done a midurethral sling and not corrected cystocele, and that leads to retention of urine, or patient already is having a detrusor underactivity and increasing the urethral resistance, is in turn causing a bladder outlet obstruction. And this is usually diagnosed by preoperative voiding status of the patient has to be learned, type of the surgery which the patient has undergone, and any other procedures like the patient has undergone TOT repair with nose correction of cystocele, that has to be examined. And physical examination to always check if the urethra is hypersuspended, patient has a significant prolapse. And the urodynamic study is not always necessary in patients with post-surgical bladder retention, because you must have already evaluated in the pre-operative session itself. And this needs to be evaluated only if the patient has an elevated post-void residue or an irritative bladder symptoms. So the evaluation of bladder dysfunction, see, all this is you need to have an idea of where the problem is starting. So first thing is you need to have a detailed history regarding the type of problem she's got. Either she's got a storage problem, or she's got a voiding problem right now, or an irritative bladder disorders which she's having. And the patient has a voiding habits which over time, which is developed some learning disorders. Is the patient is having hesitancy, poor flow of urine, inability to void, or straining to void should be found out. And incomplete emptying or split stream of urine or storage related problem should be evaluated. And sometimes the urinary retention, is it painful or painless? In acute retention, patient is unable to pass, has a palpable bladder, and chronic retention, the patient does not complain anything. Only thing is the patient has a poor flow and an overflow incontinence. Diagnosis of voiding dysfunction basically depends on the patient's symptoms and the investigations, including the urodynamic study. So we all, as a gynecologist, we know that we examine the external genitalia and vagina to find if there is an atrophic features, and check for the bladder, urethra, and the bladder neck to find if you have, if there is a hypersuspended or whether there is presence of prolapse or a diverticulum, and perform a Q-tip test or Poni's test to find out if there is stress incontinence, and check whether the patient has got rectocele or an entrocele. Check if the patient has an history of previous vaginal apical support or a descent, and bimanual examination to find out if patient has got fibroids or pelvic masses. And along with this, you need to check the patient's anal sphincter tone, the perineal sensation, the bulbocavernous reflex, and deep tendon reflex of the knee and the ankle. So the routine investigations, which include urinary examination, urine culture sensitivity, the voiding diary, voiding habits, check if the patient has got stress incontinence, and uroflowmetry is mainly to find out the flow rate, the flow time, and this is mainly to find out if the patient has got an outlet obstruction, and multi-channel urodynamics, the filling and avoiding cystometry to find out bladder stability and compliance and capacity, and voiding the cystometry to find out about the pleasure flow voiding studies. And along with the urodynamics,
Madam,
the more
please keep the
important
time.
is
Somebody has to keep the time because
electromyography of the pelvic floor muscle and external sphincter. This is mainly to differentiate between detrusor sphincter dyssynergia and functional bladder neck obstruction. As you see in the first slide, you find that
Maybe Gayatri, you
pelvic
can
sphincter,
continue up 3 minutes.
the urethral sphincter and the pelvic floor muscles is showing an intermittent contraction when it is actually supposed to relax. And this type of pattern is called as the staccato voiding pattern, which is more common found in detrusor external sphincter dyssynergia, which is not found in functional bladder neck obstruction. The voiding cystourethrogram is to find out the bladder, bladder neck, urethra during voiding, morphology and function of the lower urinary tract, and last but not the least is cystourethroskopy to find out the calibration of the meatus, the scarring, kinking, and trabeculations, presence of tumor or the stone. The voiding dysfunctions basically leads to patient going in for enuresis, recurrent urinary tract
Gayatri,
infection,
please complete in another
and
couple of minutes.
hydronephrosis is the final consequence where the kidneys get affected. And how do we prevent it? It is basically early recognition of urinary retention following a major surgery or labor pattern, and try to prevent the secondary damage because of the acute prolonged bladder obstruction. Post-operatively, always check the patient has maturated.
Madam, we have one
6
more
hours.
speaker, and after that we have a
And
panel.
measurements
Please,
of the post-void residue should be done using an ultrasound. And during a radical pelvic surgery, try to do the nerve sparing surgeries. So our treatment is basically aimed at
Gayatri, can you
increasing the
summarize,
bladder
please?
contractility or reducing the
summarize the
outflow
marks.
resistance. And this includes your behavioral therapy, pharmacotherapy,
See, just
intravesicular electrical
wait for 2
stimulation,
minutes.
clean intermittent catheterization, and sacral nerve neuromodulation, and the surgical treatment for an acontractile bladder. The behavioral therapy, which includes performing a lifestyle modification, and bladder training, especially the patient is asked to avoid at regular intervals, and the amount of 300 to 350 ml is enough for adequate detrusor contraction. And if she is not able to do a complete evacuation, ask the patient to have an assisted voiding by performing the abdominal straining or a double or a triple voiding, where she is asked to empty 20 minutes after the act of micturition. The pharmacotherapeutic drugs, which includes the parasympathomimetics, or which includes bethanechol, or an alpha adrenergic drugs, which is tamsulosin. Excuse me. Intended?
Susila, she is not able to
Sir.
hear from us, I think.
Madam, I told her, madam. Yeah.
Yeah. Then you can go for
Just
clean
summarize that.
intermittent catheterization, performing a sacral nerve neuromodulation, which is usually done in women with intact neurological system, and going for surgical treatment for an acontractile, which includes latissimus dorsi and detrusor, The newer treatment options includes the stem cell therapy or direct electrical stimulation of an acontractile detrusor. As we all know, mechanical obstruction, the most important is whenever you have done a midurethral sting, patient is having a retention, it should be identified within 3 weeks after the surgery. And whenever you think that the sting is responsible, you need to do a urethrolysis to prevent the as early as 3 weeks, not later than that, because once it causes a fibroblastic reaction, it becomes difficult to identify the mesh. In Birch Colpo suspension, remove the sutures which are obstructing it, and urethral stricture, perform the urethrolysis. In case of functional bladder neck outlet obstructions, you have to go for transurethral incision of the bladder neck. And the detrusor sphincter dyssynergia, you need to go for botulinus toxin in the intraurethral injection or giving baclofen. So voiding difficulties or a complex condition with several possible causes, which affect 6% of the women. And most often, a combination of detrusor undercontractility and bladder outlet obstruction is common. Urinary symptoms have a poor correlation with the underlying pathophysiology. The urodynamics and imaging studies are crucial for appropriate diagnosis. Complete cure might not be possible for every woman with voiding dysfunction. Our main goal should be relieving the symptoms and minimizing the long-term complications associated with it. I thank the organizers for giving this opportunity. Thank you.
Thank you, Gayatri, madam. Due to
Thank you,
a
Gayatri.
little bit of constraint of time,
Extensive
I would request that those who have questions can write down in the chat box and she can answer during the next session. Moving further ahead.
Thank you, Gayatri ma'am, and thanks a lot, Harasa, for being here. Sorry, I got delayed due to some emergency here. So thank you so much. Thank you.
Can I introduce the next speaker, Dr.
Hello, next speaker.
Dr. Tanvi CV, please.
Eliza.
Yeah, madam. Dr. Tanvi CV, please.
Yeah, Vijayawada.
Hello. Can we have Dr. Tanvi CV projected, please? Can you hear me?
We can hear you. We cannot get Tanvi's.
Okay, madam. I welcome the next speaker, Dr. Tanvi, who is speaking on painful voiding.
Painful bladder syndrome.
Session to Dr. Tanvi.
Thank you so much. Thank you, Shobhana ma'am. Thank you, Manoj sir. Thank you, Patnaik sir. And to all my seniors.
There's echoing. Please clear it, please. Debolina?
Debolina, please.
Yeah, I think we are right. Now the echoing is stopped.
Yeah. So I'll start sharing my screen.
Let me introduce Dr. Tanvi. Welcome, Dr. Tanvi. She is a renowned urogynecologist from Hyderabad, and recently she got fellowship also on Urogynec. So I heartily congratulate her. So welcome, Dr. Tanvi. It's really nice having you on board.
Yeah, her specialty is hysteroscopy, I believe. And
Yes, ma'am. Minimally invasive, ma'am.
It's very rare that she puts her head out of the uterus, but because the IMS is her mother's place, she just put it out for our sake, right?
No, ma'am. No, ma'am. It's only in the bladder, nowhere else. Bladder and the uterus.
I'm just joking. But Tanvir is a hysteroscopic surgeon, but she's a urogynecologist. Definitely, she's a urogynecologist, and so she's here to talk to us about bladder pains. Thank you, Tanvir.
Thank you so much, ma'am. So to start off without wasting any time, bladder pain syndrome, interstitial cystitis, just to give a little background, in India, there is a group called GIBS from the Mumbai, and they do a lot of meetings and a lot of work on bladder pain syndrome. They also have a patient portal where they get all patients together to interact. So I think that's a great way, because this particular problem is also something where women need a lot of counseling and understanding of the problem that they have. So I'm just, because it's a very wide topic, it's not very well understood. So I will not be going too much into the management, just giving you a brief overview, but trying to make you understand what is bladder pain syndrome. To start with, initially, Dr. Samuel was the first, Dr. Gross was the first who believed that interstitial or parenchymatous cystitis is a superficial disease. And then Dr. Skinny was second, who found it to be an inflammatory process with an ulcer. But in the end, it was Dr. Gail Leroy Hanna who coined the term Hanna's lesion in the bladder and ulcer, which he identified and described, which I'll be showing you as we come across. There are various guidelines from around the world, but because we are in India, so I would like to put across the Indian guidelines, which is the Gibbs guidelines, where any pain or discomfort or dysuria in the lower abdomen, which is worst on full bladder for more than 3 months and is associated with lower urinary tract irritative symptoms such as frequency, urgency, nocturia. And this is the frequency, urgency, and nocturia is associated with pain. So that is the striking symptom. We have to ask them whether it is associated with the pain or the feeling of wanting to rush to the bathroom for the fear of leaking, or is it the fear of the pain? It is generally now it's accepted to do a cystoscopy routinely, even by the Gibbs, and any other pathology has to be ruled out, such as tuberculosis or fibromyalgia or irritable bowel syndrome or any other infective pathology, or even cancers for that matter of fact, has to be ruled out. So there are two types now, with Hanna's lesions and without Hanna's lesions. So treatment is based on this particular classification. Going back to the epidemiology, it is underdiagnosed and misdiagnosed. So the prevalence is found to be 3% among female, and female to male ratio is 5:1. The prevalence of bladder pain syndrome or interstitial cystitis in India is about 1.25 million patients. And in India, many a times it is treated as tuberculosis, even though, yes, tuberculosis is very much prevalent, but if the patient is not responding to the treatment, I think you must look into this particular disease. Visceral sources of pelvic pain are various. We know gastrointestinal is the most common, and the second most common is the bladder, that it's accounting for almost 30%. So what exactly happens here? We do know that there is a urothelium in the bladder, and the gag layer covers it and is protective. It does not let anything penetrate. When this defense mechanism is disabled, or when there is some kind of dysbiosis here, then the urinary irritants do penetrate this uroepithelium and activate the nerves, muscles, and the mast cells, causing injury. The causes can be many: repeated urinary tract infections. It could be repeated use, long-standing, holding urine for long. It could be an autoimmune. It could be genetic also. It could be hapless. There's so many different causes or etiology of bladder pain syndrome, but we can't really pinpoint at this point. But we do know there is tissue damage. So hence the pain and hypersensitivity increases, and there's also fibrosis. So what happens following this? There is a lot of association with other diseases, other problems. And this is because there is upregulation of the visceral nerves, which is mapped poorly in the central nervous system. So there is a lot of crosstalk between the visceral organs, such as the bladder and the uterus, and also the bowel. Hence, the neuronal crosstalk causes the pain to be poorly localized and characterized, and the symptoms are very vague, because they do complain of very vague lower abdominal pain, where you cannot really map where the pain is arising from at times. Phenotype is the most important. So phenotype is the Hanna's lesion that we do find in interstitial cystitis. There are also non-Hanna's lesion types. So thanks to the phenotype that we are able to define it into these two types, that Hanna's and non-Hanna's, And this is useful for treating the patient, diagnosing and the prognosis, even for therapy and for newer treatments which are coming underway. So why do we need to treat this? Because yes, it does impact the quality of life. Many a times these women are considered to be depressed or they have a psychological problem, but no, there is a problem. So you need to understand that you need to believe the patient that yes, there is a problem if they go on complaining. So there is pain, urgency, and frequency. So hence there is limitation of sexual intimacy, sleep deprivation, comorbidities do cause depression, anxiety, and 6 times reduced ability to work. Dysmenorrhea, sexual activity, desire, organism, everything is affected. So sexual problem is one of the major problems with bladder pain syndrome. So we do know that it is symptom driven. It is a diagnosis of exclusion, and feeling pain as opposed to dysuria is the most striking symptom of bladder pain syndrome. So what do we need to do is take a good comprehensive history like we do take in our general questionnaire. Along with that is the added questionnaires of pelvic pain urgency and frequency, which is a simple 8-scale questionnaire, very easy to take in your clinic, not more than a minute. The ICSE is a long questionnaire, but it gives you a more comprehensive, a better understanding. There's also a King's Health questionnaire, which gives an idea about the quality of life of the bladder, bowel, and sex. So symptomatology, very important. Pain perceived related to bladder, urgency, frequency, dyspareunia, they do complain of anal discomfort, and there are many triggering factors. The stress, different diets such as citrus fruit, or having a coffee or tea, or even certain masalas or kava, that we found an increased number of cases of interstitial cystitis or bladder pain, especially during COVID, because there was a lot of trend of kava being taken, so because it's supposed to be good during COVID, but on the other hand, it did trigger the bladder pain syndrome. Failed response to treatment and high scores on the pelvic floor scale. So we've already, I've already just told you about different, conditions that can be confusable. Carcinoma, most common, so rule out if there's hematuria, repeat the urine, or go ahead with cytology and refer to a urologist. Any infections, stones, diverticuli, prolapse, and endometriosis. Certain overlapping conditions such as depression, pelvic floor dysfunction, and myofascial pain is quite common, almost 87% of the time. So do examine this patient. When you're examining the patient per vaginally, do identify whether the muscles are tight, whether there are myofascial bands. So if the muscles are very tight, they may need some relaxation. Do not ask these women to do Kegels. If they complain of low pain abdomen, where the UTI is ruled out or any other condition is ruled out, do not advise them, because Kegels exercises is contraindicated for bladder pain syndrome. So coexistent, there can be irritable bowel syndrome. Vulvodynia is almost 50%. You see vulvodynia and IC patients together. Also, overactive bladder is also very commonly seen with bladder pain syndrome, anxiety, endometriosis. So if you find that they're not responding, you do a vaginoscopy or you do a laparoscopy, make sure it's not endometriosis. Focus physical examination, very important, which I've already told you. Look for the tender points, examine them, press, do an per speculum, do an anal examination. So you will be able to find some tenderness in certain points. So you can identify that point, give them a local ointment or give them oral medication, which helps them with the pain. Because for these women, pain is the only main problem. So bladder diary and voiding diary gives us a lot of information. These patients void very frequent and the volume is low. With time, the capacity of the bladder does come down. Urine analysis, rule out urinary tract infections, and post-void residual volume is done to rule out other bladder outlet obstructions and neurological dysfunction, like Dr. Gayatri has explained beautifully. Cystoscopy gives us an idea of Hunner's lesion or even glomerulations and erythema, where you have these bleeding points. So glomerulations may be present in 45% of healthy patients. Now, as you see in the video, you do find a central scarring with neovascularization on the sides. So this is a classical Hunner's lesions. They are early and they are also late, where the scarring is quite much. So you can treat it cystoscopically. So hence cystoscopy is now being encouraged to do early in these patients, because if you do find Hunner's lesion, you treat them, you can fulgurate them right there. So from our Indian data, Nagendra Mishra sir has done a lot of work. He's from Gujarat and he's done a lot of work. He's internationally known. And from a very long time, he does support the idea of doing a cystoscopy. And he says not every patient is ICBPS. So initially rule out tuberculosis, carcinoma. And then if it is ruled out, you must think about bladder pain syndrome. And an ultrasound, a simple ultrasound is very important for kidney, ureter, and bladder with measurement of post-coit residual urine volume. Another paper from India in the Indian urology is the study of female sexual dysfunction, where they did find that female sexual dysfunction is very high even in Indian women, and they do complain of it when you ask them about it. So Dr. Rajesh Tineja sir is also world renowned, and he has come out with a modified clinic score where he's added sexual dysfunction and psychological impact of bladder pain syndrome in these women. And he was able to stratify this clinically, the severity of the disease, and also follow these patients up. So initial measures is patient education, treatment of comorbidities, and psychosocial support. So treatment of comorbidities, because there is central sensitization, psychological support is very important. So you don't send them to a psychiatrist, but you need to counsel them initially. Speak to a psychiatrist if you wish to include them, and tell them why you're sending them and teach them some relaxation techniques. So most important is to prevent the IC flares, treat the aggravating factors and comorbid conditions, and certain activities such as prolonged sitting exercises, certain exercises should be avoided. And sexual activity, maybe certain things has to be avoided, which a psychologist or a sexual specialist can help out with. So diet, coffee, chocolate, alcohol, citrus, spicy food are not really studied, but can be avoided, because we do find a lot of flares. Application of cold heat locally over suprapubic region also prevents flares. Yoga, Pilates, and walking has found to decrease IC flares. So time voiding. So you ask the woman to urinate by the clock. So every 2 hours to start with, so that she does not have that pain. To avoid the pain, she has to go by the clock. Pelvic flow therapy is now widely studied. There are a lot of papers on acupuncture and different pelvic behavioral, comparing behavioral and pelvic flow therapy. So it has to be done for 1 hour per week for at least 12 weeks. Various oral medications, you can start off with antihistaminics and amitriptyline, also local gabapentin and amitriptyline in low doses, such as starting from 25 to as much as you can go to 75 milligrams orally per day in the evening before bedtime. Also pentosan polysulfate 100 milligrams 3 times a day is given for 3 months initially, and then you can stop. And because if you give it for a long term, you have to make sure that the patient doesn't take it for a very long time, pentosan polysulfate, because it can cause certain eye problems. So because there can be a misuse, it has to be, we have to make sure they don't use it for longer than that. It has to be under our supervision. And it is an FDA approved drug, so it is quite safe to be given for 3 to 6 months. There are various intravesical installations. Commonly, if a patient comes with pain, you can just put in a catheter, put some lignocaine in a saline, or just push in lignocaine with a syringe. That also can give her some relief. Or you can use heparin 50,000 along with the lignocaine combination and an antibiotic. So these do help them to overcome the flares. Endoscopic surgery, which I've already spoken about, transurethral ablation, hydrodistension, it does help. It is proven. It's been done for a long time, not totally proven. Some believe, one school of thought is yes, it works. One school of thought is you shouldn't. But you have to be careful, because there are cases of bladder rupture. And electrostimulation, such as neurostimulation, is being studied, and nerve stimulation, tibial nerve stimulation, is also being studied in acupuncture. So the conclusion here is, it is a diagnosis of exclusion. Sometimes it may take up to 2 to 3 years. Every patient who comes with a UTI, please do not advise antibiotic as a first step. first give some non-antibiotic medication. If they subsided, great. And if they keep coming back with repeated infections, do a culture, just make sure that it is not something else. And if you feel you have a doubt, please take an opinion, because multimodal approach is the answer for this particular problem. Thank you.
Thank you, Tanvi. Thank you very much for making very commonly seen patients which we are unable to treat many of the time. But your presentation made it gave very useful tips for clinical treatment. Now directly switching over to panel, those who have questions can put it in the chat box, and both the speakers
Tanvir, I would like
Thank
to
you,
ask
thank
you
you.
one thing.
Yes, ma'am. Yes, ma'am.
You said that the bladder would rupture with the hydrotherapy. Because
Hydrodistension,
normally
ma'am.
we have whatever hydrodistension, but we are used to putting so much of urine in the bladder and it doesn't rupture. But a woman with this problem, it will rupture. So what is the difference between the two bladders, and with what amount of water, what amount of fluid has this, any report of rupture that you have read in the literature? How much water they had put in before it ruptured?
So, ma'am, what has been observed is, like, normally the bladder capacity can go up to 400, 500 ml. You can expand the bladder capacity. The bladder capacity in normal bladder. So hydrodistension, when hydrodistension is done, normally in bladder pain syndrome, in a severe cases, it is sometimes as less as 120, 150, or even 200 ml, and up to 300 ml. So if you go on expanding and you see there is a lot of stretching, they do find that without realizing, when a lot of urologists go on putting in a fluid, so they have seen ruptures where they've gone up to 700 ml. The bladder does
That's what I'm
expand.
saying.
Yes,
That's
ma'am.
what I'm saying. People can put in so much of fluid when we are doing
But
this.
ideally, you should not, ma'am. You should stop at least 400-500 ml. It's.
I've not done it. I'm not telling you this.
Yes,
but
ma'am.
quite often when you put in a catheter, you see so much of fluid coming out into your.
But if you notice how much is coming out,
the sisters are saying that 500
Yes, ma'am.
ml is there, 600 ml is there, and all that, and you are telling me 200 ml will rupture. So
in
I was wondering.
ICBPS, yes, ma'am. In ICBPS, because the bladder capacity comes down, so yes, it does, ma'am. In severe cases, if you go beyond.
Another thing I got scared when you were saying you cauterize those Hanna's lesions.
Of course, yes, ma'am.
Will you get some VVF or something when you cauterize?
Not at all, ma'am. Not at all.
Okay,
That,
no problem.
yes.
Okay. Fine. So scary, not to cauterize the bladder.
No,
We're all
no,
scared
no.
of the bladder.
Ma'am, no, ma'am. It's one of the most forgiving organ.
Yeah. Okay. So anybody else wants to ask us something?
Thank you, Tanvir. One word.
Yes.
Thank you, Tanvir. It's a beautiful presentation, and it's a difficult subject to be discussed in a gynecologist forum. Second thing is that the capacity of the bladder in bladder pain syndrome or interstitial cystitis is reduced. So, trying to distend a bladder of a patient of interstitial cystitis will cause more pain, and there is a chance of rupture. And yes, Madam Sobna, because these days they are doing a laparoscopic VBF repair, and they are cutting bladder through and through with a electric.
I know that all I know, but
cauterizing inside, and it's a small bipolar pinpoint cauterization. This normally happens, and that does not cause. If it is a very deep burn for a prolonged period, this can happen. Even if you puncture with a needle or a Berry's needle also, the bladder is punctured, that automatically fills up. Thank you. That's my comment. Thank you very much.
Thank you.
Tanvir, one more thing. What about putting this local inside the bladder? You said, you put local, local with little water and all you put. That will only give little effect. No, will it last? That effect will last.
When installation go on for around 6 weeks or 12 weeks, there are different protocols from different literature, ma'am. So I follow what Rajesh Taneja sir follows: heparin, hydrocortisone, lignocaine. So you put in every weekly. Ideally, he says twice weekly, and then weekly once. You put it for up to 12 weeks. So basically,
how long that fluid has to be there inside?
So we leave it for about half an hour, something, ma'am, 15-20 minutes to half an hour.
Lignocaine will last for 1 whole week.
Yes, ma'am. They're quite comfortable. So we have patients who come in and we just put it in, put a catheter, just instill, and then leave
After
them.
half an hour, you send them home.
Yes.
And do it every week.
Yes, ma'am. They come because they have pain, so they want to get relief. These are certain severe cases. So
No,
then they get
I'm
less.
quite surprised that lignocaine effect lasts for 1 whole week. Because
No,
we
no,
all
ma'am,
take
because we also
like
use heparin and hydrocortisone along with it. No, ma'am.
Great. Okay, good.
Beautifully taken this topic, Dr. Tanvir. It's one
Thank you,
of my
ma'am.
favorite topics. Basically, what Dr. Tanvir has said, has tried to convey with everybody that, most of the cases are treated for other illnesses than the bladder pain syndrome. So we have to keep an eye, we have to keep it in mind that it could be a bladder pain syndrome. And as she has suggested stepwise management, starting with lifestyle to eating habits and everything, that should be kept in mind. And the patient should not be shunted from one, doctor to another. That is very, very important message, which all of us should keep in our mind, that, a patient comes to us, take a detailed history, and then examine, go for investigations, whatever required, and then manage it well, and don't shuttle down the patient from one side to another.
Yes. Thank you, ma'am.
Thank you, Tanvir, once again. And then now we are moving ahead with our panel discussion. I invite Madam Dr. Shobna ji and all our panelists, Dr. Soni, Dr. Bipasa Sen, Dr. Jyoti Jaiswal, Dr. Bhavna Madam, Dr. Ranu Patni, Dr. Anjana Chauhan, if you can participate, if your throat is clear, Dr. Mumtaz and Dr. Somlata. Over to
Can
you,
you please
madam.
read out their CVs, Dr. Riddhi?
Yeah. So,
Dr. Bipasa is from Calcutta. She is the treasurer of Indian Menopause Society. She has done many posts in Indian Menopause Society, and she does a lot of social work in Calcutta. She works in a government college, and she is a national money giver of IMS. So, and a dear friend.
That's all.
Yeah.
That's all, Shabna.
Okay. Next, please. Dr. Jyoti Jaiswal is from Raipur. Dr. Manoj Chellani is right hand or left hand or middle hand, I don't know. They are all very great workers in Raipur. She's Joint Secretary of Indian Menopause Society. She's was a quiz queen of IMS when she just recent past, and I invite you, Jyoti, heartily for this.
Madam, thank you for inviting.
Dr. Bhavna Seth is a very great activist from Bharuch, and she has done a lot of public awareness programs in Bharuch. She has even stopped people from drinking. She goes and conducts plays in the rural areas. She is a very great worker with 40 years of experience from Gujarat, Bharuch. Welcome, madam. Dr. Ranu Patni was, when I joined IMS in 2009, she was a very great figure in IMS, and now she's there. But we want all the past and present everybody with us, and so she is trained at Tata Memorial Hospital, Mumbai, practicing gynec oncology since 20 years. She is the first trainer and mentor for gynec onco fellowship in Rajasthan, and founder president, state chapter AGUI, and editor of a book called Current Concepts in Endometrial Cancer, published by Springer. That's great. Editor-in-chief for Journal of Midlife Health for 3 years, and she was a great event. Dr. Anjana Chauhan is an oncologist from Ahmedabad. She's the president of Ahmedabad Menopause Society. She's ex-committee member of AOAIGI. She has got the Best Paper Award, second prize at TMH Mumbai. Dr. T.B. Patel Young Research Scientist Award, and published more than 30 papers in national and international journals. And, welcome, Anjana. She has got a bad throat. I hope she can take part today. Next, please. Dr. Mumtaz is from Kerala. Next door to me, she's from Perindalmanna. She is a professor in the medical college, and she does a lot of webinars of conferences, and she's a regular figure in Kerala. She has got the Kalyani Kuti Amma Memorial Gold Medal, Tampan Gold Medal, Amarendranath Dan Prize for Best MCH Paper, K4 Gold Medal, Wonder Foxian Award. Indeed, she is a great academician, as you will realize. She is a very good speaker, but I have just got her as a panelist today, but otherwise she's a very great speaker and very good orator. Yes.
Thank you, ma'am, for the kind words.
Dr. Somlata, I do not know much about her, but she's a gynecologist from Bhargav Nursing Home, Vijayawada. It is my endeavor to include all societies and all speakers from all societies in this IMS webinar series, and she's a face of Vijayawada in this, besides the first speaker that we had and all the organizing members. So now I'll share my screen.
Thank you.
So we have great panelists pan India. It's all over India. So good to welcome you all.
That is because of Manoj Chelani's endeavor to include the whole of India in this program. And I really appreciate your effort in that, Dr. Manoj.
Thank you. Thank
It takes
you.
a long time to call up people and get everyone to be ready for these things. And, you know, it is a lot of effort that is there, and you have done it. And we thank you for that. Manoj Chelani, as you know, is from Raipur, and he's also now got into Foxy committees. So
thank you.
Okay. Okay, now here we go with a very important topic that Manoj has given me, that madam, you conduct a panel on UTI. And this is not my topic, it is Manoj's topic, because he is a urogynecology person. So now each panelist, one after another, will you please give me your first line of antibiotic in UTI and why? Then only I'm going to go into the panel now. Okay, we start from the oldest member that I knew in IMS, Dr. Ranu Patni.
Hi, Shobna. It's
Yes.
a wonderful program, and thanks for having me. I too have a bad throat, but I try to speak. So actually, if it is UTI in isolation, I go for nitrofurantoin to begin with. If there are associated symptoms of pelvic inflammatory disease or maybe colitis, then maybe till the report of the urine culture comes, I would like to go for
So,
something
okay,
that
your first
covers
line of
both
therapy
them,
is
like
nitrofurantoin. Now we are all shifting from fluoroquinolones to first line therapy, nitrofurantoin. That's news to me now. That's news that we are giving out from this panel. Dr. Somlata, the local girl, your words, please.
Thank you, ma'am, Shobna ma'am and Susila ma'am for giving me this opportunity. Actually, we are giving single dose fosfomycin 3 grams, ma'am.
Okay, isn't it expensive, Dr. Somlata?
Yeah, ma'am, but single dose and patient acceptability, and also
My
like
goodness.
very less
is
side
that
effects.
anyway, when the question comes, I'll talk about it. So fosfomycin and nitrofurantoin is already out of the box. Anju Soni?
Yeah, with the
Secretary General.
UTI being coming so common and quinidine group coming as resistant antibiotic, nitrofurantoin, and then the older drug which we had forgotten earlier, trimethoprim. We used to, give it earlier, many years ago, is again into our, bag, which we can give. And I have seen that, whenever in recurrent UTI we do cultures, this is one of the another drug which is now with us, and it is very effective.
So trimethoprim.
Not very expensive also, and it's very, very effective. It can be easily taken.
Okay, Jyoti Jaiswal from Raipur.
Nitrofurantoin, as it is easily available in my department.
Oh God, I'm getting bored now.
It is easily available in my department free of cost. And for the uncomplicated UTI, I used to give this. For the complicated UTI, sometimes we used to give fluoroquinolones.
Okay, let me go east and find out if there's a change. Vipasa from Kolkata, she's also in a medical, she's also in a government college where everything is free.
Well, I am in line with Jyoti because I got first
Mumtaz.
nitrofurantoin.
Now let me go to Mumtaz.
Now
Let me find out. Kerala.
Use antibiotic as first step. Anyway, if it is antibiotic, then nitrofurantoin.
Nitrofurantoin. Mumtaz.
Yes, ma'am. We are also with nitrofurantoin these days. there was a time when every patient walked in, got an ofloxacin, but now we have switched over to nitrofurantoin.
So now, Bhavna madam, you are a very old practitioner, 40 years, senior most in this panel. Tell me, nitrofurantoin again?
For gynec patients, trimethoprim.
No, sorry, the Bhavna madam. Bhavna Seth from Bharuch. Please put on your mic if your mic is off. I saw that you had logged in. Dr. Bhavna, has she logged out? She lost her connection.
She said, you are not audible. You are not audible. Please put on your mic. Put on your mic. Unmute yourself.
Yes.
Unmute yourself. No, we can't hear you. Go to the left side of your screen. There is a red button. Please click on it and unmute yourself. Lower portion of your screen. No,
my
we
first
can't
choice
hear.
will be.
She's unmuted.
She's not unmuting
My
herself.
first choice will be the nitrofurantoin.
Okay, fine. So now
My
we don't.
first choice is
Anjana, can you speak?
nitrofurantoin.
And do you have a difference of opinion, or you are also nitrofurantoin?
No, madam. We give what nitrofloxacin.
Okay.
Norfloxacin, sorry.
Norfloxacin. Oh God, at least somebody.
So
now
400 milligram, and we don't go for a culture. The urologist say if you have UTI, no need to go for a culture. Give nitro. They say nitrofuran. Now the drug has changed, but we give norfloxacin, and we continue. If it is cured, then no need to repeat or something.
So whole India is now with nitrofurantoin. So now let's go on to our panel. Now, Dr. Somlata, when would you call an attack of UTI to be recurrent?
Yeah, ma'am. Actually, means in the last 6 months, if the patient has 2 episodes of UTI with symptoms like dysuria, frequency, urgency, and suprapubic tenderness, and or 3 episodes in the preceding year, then we call it as a recurrent UTI.
Okay, 2 episodes
In
or
6
3
months?
episodes in a year without symptoms, right?
Yeah,
Now,
yeah,
let me tell me, what is the difference between recurrence and relapse, and why should you know the difference?
Yeah, recurrence can be a relapse or a reinfection, which is reinfection is more common and less complicated. Relapse means actually we see within the after completing the antibiotic treatment within the 2 weeks. Means like it's like we should think of some other causes like any calculus, any calculi are there, any obstruction is there. So relapse is like with the same bacteria by which the patient got infected previously, whereas reinfection with this different microorganism.
So you have to check, like, no, you have to really take a proper history and find out what is what.
Yeah.
Then only you can decide, no? Okay,
Yeah,
then
yeah.
now she says, suppose if there is a relapse, you have to look into other things. And Dr. Anju Soni, what in particular you should look for when you think there is a relapse? That it is not a reinfection and that it is a relapse.
This is very important question. Basically, whenever we talk of recurrent UTI, it is, I think, one of the most common suffering a woman has in her life. And, we have to, as we, in any other case, we take a detailed history and then examine the patient locally. And when we examine the patient because most of the women are perimenopausal and postmenopausal women. So we examine them locally, look for any kind of atrophy, look for any kind of masses near the urethra. Maybe there could be a diverticulitis, which can lead to this kind of recurrence all the time. Then we look for any kind of prolapse, any kind of stones maybe, or maybe some kind of fistulous tract between bladder and the, vagina because some other, or it could be overactive bladder syndrome, wherein the capacity of bladder, is reduced and there is increased amount of residual urine and patient is unable to void completely.
Yeah, because very old people, they have detrusor weakness, they don't void at all.
Yeah.
And the urine is logging in the bladder and you don't realize it.
So the urine remains, there is a lot of residual urine which remains inside the bladder and patient is unable to void completely. And this we can measure by either doing a catheterization or ultrasound. And if the amount of urine, residual urine is more than 95 ml, then 90 ml, then it is considered. Of course, normally 30, but 30 to 60 is in between. Beyond that, around 90 is considered more urine. And those are the cases we have to look into and find out the cause, because that is one of the biggest reason because of
you cannot just ask the patient, get the urine report, get the culture report. You have to actually examine the patient, take a torch, look everywhere. So, and I even catheterize and see if there is residual urine, right? Or get an ultrasound now. So thank you, Dr. Anju. Now, Dr. Jyoti, menopause. Menopause means therapy. So let us know about genitourinary syndrome of menopause.
Yes,
and whether by every patient, now all of you said nitrofurantoin, because this is the Menopause SHE conference. Will you say estrogen for everybody?
So what's the question for me, madam, here? Yes, the majority of the patients of genitourinary syndrome includes the recurrent UTI. And if you ask me that whether we should give estrogen to all, so my answer will be no. UTI can be of because of various causes. One of them is GSM. It's not always a GSM.
That's
so
very
estrogen is
important
not
message
the
that you have given. It's not for everybody.
Yes, it's not for everybody. Whenever there is a need of estrogen, only then it is required. Otherwise,
What is the
not for
age
all.
limit? Suppose 50-year-old, 40-year-old, 60-year-old. Is there something age where you will start this?
Basically,
Or
madam,
only if you see an ulcer on the vagina, you will start redness on the vagina. What is your indication? Take on that.
Madam, I will not go by the age here, but will go with the symptom and the sign present over the local parts. Like
Okay.
if the
So only if
patient
it is red, you will give. If it is not red, you won't give. Right?
If it is thin parchment, like you need to grow somewhat of the mucosa there, then definitely I will be giving. But
Okay.
if it is you feel that vagina is moist, it is not dry, it is not thin, and there is no vaginitis or urethritis, then I will not give.
Okay, so that's very important. It's not the age, but it's the moistness of the vagina, it's the color of the vagina, all that, then you have to examine the patient. So what are the local preparations and how long you will give, what is available in Raipur and what is available everywhere?
Madam, basically preparations are of various types, like the cream, the tablets, the capsules, the rings, and even the oral tablets sometimes. But basically what we use at Raipur and what is available at Raipur is the conjugated equine estrogen and the estradiol. Two creams are very easily available, one with the name of Evelon and another with the name of Primarin. Still, we are waiting for the estradiol, 17 beta estradiol, though Abbott has come with some gel, but the cream I have not found here. And even the rings and tablets, it is not of
so how long
much
will
of
you give?
experience.
Patient has come with recurrent UTI and you are giving cream and they have to keep it in the fridge. How long they should use it?
I wish to share with you here that earlier, before being a part of the menopausal society, हम बहुत डरते थे and we used to give it only for the 21 days or hardly 1 month. But now we know it well that these type of local preparation do not cause any endometrial growth. So we can, at least we should give it for 3 months to 6 months. And even if required, it can be given up to 1 year without any other extra endometrial thickness monitoring. Yes, if you need, after that, you need to do the monitoring.
Okay then. So now, Vipasa, how do you know patient is coming with dysuria and things like that? Urine is showing little puzzles. That doesn't mean that she doesn't have anything else. No. How do you know that UTI is just added on to some other problem or something like that? You know, how do you actually evaluate a patient? Anju has already given us what all else can be there. But how do you really find out what she has said is there, or what is the difference?
Yeah, I have to look at the patient holistically, because in this age group, many of the patients, they have got some sort of vaginal atrophy and then soreness, which may lead to recurrent irritation of this, and these are now, if we go for urine culture, we will see that there is no infection at all, and there is again candidiasis and other sexually transmitted diseases are there in differential diagnosis, but in practice I don't find it much, but I must look for it. And non-infective cystitis is a major part of this group of patient. And also,
I know, just now Tanvir gave us a big lecture on that. No?
Yeah. That's why she told, now don't start antibiotic as first line of treatment. That is a very good thing, and we should look for some local masses like suburethral, this
that Anju has already told us earlier.
And of course, I will look for other comorbidities, whether she has got diabetes and all these things. So considering all these things, and if there is urine culture, some infection, then only I will call it UTI. Otherwise, it is harm.
Okay, quickly, Anju wants to say something. Anju.
Add that, since in menopause the vaginal flora is changed, the pH is changed. That is very, very important thing.
Yeah, that's, we have already said that. No, we will come to that later.
Yeah.
Now, we have already said, look for diabetes, look for renal problem, everything is done. Now, Mumtaz, E. coli is, is fluoroquinolone is resistance is on the high, and everybody is resistant to carbapenem also. And now all the panelists have jumped up and said they will give nitrofurantoin. So now I don't think Mumtaz has anything to say, but Mumtaz, what do you see? Your take on this?
Yes, ma'am. Most of the time, previously, we used to be very confident in giving fluoroquinolones for these patients like naproxen or ciprofloxacin. And we used to think that these drugs are very safe also. They are not without side effects, which could be sometimes serious also. But that happens only with prolonged usage. But what is important is that nowadays we are seeing resistance to these drugs and we are forced to give other drugs. And
so you have justified all the panelists.
Yes, ma'am. And one important thing is that we should always think beyond the bladder. Like if there is an infection beyond the bladder, that is, if there is a symptoms or signs of pyelonephritis is there, maybe we should think about taking the culture and then starting on parenteral antibiotics. But if it is only just cystitis, patient coming for the first time, it's a good practice to start with nitrofurantoins. And we are not very comfortable with the trimethoprim these days. And fosfomycin could be a little expensive to some section of people. And also this 5 days nitrofurantoin is found to be more effective than a single dose of fosfomycin at the end of 1 month. It used to, little chances of recurrence with 5 days nitrofurantoin. That's also important. The course should be to 5 to 7 days.
What is this fosfomycin? It is supposed to be a very, very old drug. Now, when the medical rep came, we thought it's a new drug. Actually, it's a very, 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 very old drug.
Maybe it's a very old drug, but I came to know about it only few years back only.
Yeah.
And it is in powder form, and the patient is easy to take. She can take it in with a glass of water, and just a single dose is enough. Single sachet is enough. And some people have this. They say 2 doses should be given 72 hours apart.
Most people are giving only 1 dose and finished.
1 dose we usually
give. Otherwise, you can give 2 doses after 3 days.
And ma'am, once in 10 days, some people advise once in 10 days also for recurrent infections.
So anyway, even comparing with fosfomycin, it's panelist's choice, nitrofurantoin Zindabad. So, but can you use it in early pyelonephritis?
No.
All your favorite people.
No, nitrofurantoin doesn't reach up to the therapeutic levels.
Only for bladder, because it gets excreted very fast.
Yes.
So it won't stay for long in the kidney.
Yes, ma'am.
And plus, otherwise, you can even have neuropathies when you have a chronic kidney disease, if you are not aware of it. So you have to check the creatinine also, I think, no? In recurrent abortion, recurrent UTI, sorry, I'm talking abortion. So that is there. So nitrofurantoin is Zindabad for everything, but not for kidney failures and kidney. And if there is early renal failure, it won't act on the kidneys. So panelists, please be careful. Huh? Dr. Bhavna said, what is post-coital prophylaxis?
Yeah, in women who are sexually active, and especially if they are elderly, then sexual intercourse can lead to repeated urinary tract infection. And if it is we know that sexual intercourse is the cause of UTI, then giving a course of antibiotic 2 hours, within 2 hours of sexual intercourse is called as postcoital prophylaxis. We give several antibiotics can be given, something like a combination of trimethoprim and sulfamethoxazole. We can give nitrofurantoin. We can give fluoroquinolones like ciprofloxacin or norfloxacillin or ofloxacillin. So giving within 2 hours of intercourse is very essential to prevent the postcoital UTI. But studies have been showing that we can give it for a long time, which is known as continuous antibiotic prophylaxis, where we can give it for as long as even 6 to 12 months. So that we can give the antibiotics which I just mentioned, we can give it for a longer time also.
No, but the problem is yesterday I had a patient who had a pelvic infection, and I thought, like, I was making the slides, no, I thought maybe the same thing I can do for even chronic pelvic infection. She had a retroverted uterus with the cervix touching on the urethra, and she was, many gynecologists, many urologists had seen, and she was suffering like anything, little bladder fills up and then she gets upset, and she was happy with the antibiotic I gave. And I gave a prescription of Cephalexin 375 milligram daily for 1 month. And the pharmacist is asking, is it for 3 days or 30 days? Please call up the doctor and ask. So this is what will happen if you give a prescription for 30 days for one antibiotic. I don't know how many of you have given this, and anybody's given this antibiotic dose for 30 days in the panelists?
Yes, Shobna, for acne, he prescribed doxycycline for a long 20-30 days for acne. It
so Bipasa has given. Somebody else also said. Who was that?
Yes, I also have given.
Madam.
I have
Yes,
given.
madam. Who is please tell who it is. I can't hear.
Dr. Bhavna. Dr. Bhavna, yeah. I have given.
For 30 days, you have a pharmacist doesn't question you.
I have 83
no, but I call her every 10 days. I call her 10 days and then I extend it 10 days, 10 days, 10 days.
Oh, you are very smart. So people, please, if you write the 30 days, they will not listen to you. So that's a very smart advice. Don't give for 30 days, 10 days, but you are allowed to give. So now Dr. Ranu Patni from Jaipur, what is self-start treatment? That means they don't have to visit gynecologist also now.
Shobna, first of all, I would just request you to adjust your camera because we can see only half of your face.
Oh, it is not necessary to see me, no?
That's nice now.
Okay.
Yeah. So, actually, I don't know, surprisingly, in my practice, many patients come having taken azithromycin of their own. I don't know what is the reason. They take
azithromycin doesn't have urinary concentration, no? Does it have urinary concentration?
But it's a kind of alternative medicine. You can say patients administering themselves with treatment. So that's probably the thing here. But yes, this is self-medication, and this patient starts antimicrobials, and which has minimum side effects by themselves. And any of these they can take, like Bactrim or nitrofurantoin or fosfomycin or beta-lactams and fluoroquinones. These are, of course, to be given only when
you can give a prescription and say SOS you can write and give.
Yeah, definitely. And for the last question that you mentioned, yes, we do have to give prolonged antibiotics many a times for resistant cases, or maybe the organism goes on changing. Then for urinary tract infections. Until the time sometimes you don't get a culture report, you can get symptomatic relief by pyridium for at least 2 days or so, and then explain to her that the color of the urine might change with that.
Okay.
That is how.
Pyridium is still in the market and heavily used by Jaipur people.
It is. I also give, if the patient has too much of spasm, then I also give many times flavoxate to the patient.
Okay, this has gone out of my prescription listings, but it's coming
but
from
it
Jaipur.
Does work.
Okay, now let's go to your neighbor, the neighboring state, Gujarat. Dr.
Yes,
Anjana, I don't get D-mannose. I get it in homeopathic dose mixture, like, cranberry, D-mannose, everything mixed up. This rep come and gives. I tell them, you go and buy D-mannose from the Amazon. You will get it from there. So what is the role of D-mannose? And you are an oncologist, I know that, but I'm sure that your oncology patients also get recurrent UTI. So tell me, is there a role for D-mannose in treatment of UTI?
Madam, there is a role. It inhibits the adherence of the urothelial cells. The fact is, in oncology, what happens? We keep catheter for a long time. So probably when the catheter is kept, now the urologist say there is a film form on the layer of the epithelium, and in the film there is a small thin film is formed, and below the film there is a bacterial content. So many times this bacteria causes infection, and sometimes this plays a role, and it clears of the infection, doesn't allow the bacteria to adhere to the epithelium. I personally think maybe it is working, but definitely in UTI.
What is the dose you give and how do you give it in Ahmedabad? Because how do you get? They don't have a proper dose in literature. 250 to 3 grams, they say. How are you giving it in Ahmedabad?
Madam, most of the urologists they give it in some sachet form, and you say you take it.
That's very costly, those sachets. How much costly is it?
At present, I don't remember, madam. One of my patients, I have not given
Earlier, I used to give it the sachets, but it's not available in my town anymore. So I get it from the net. But what is the dose?
Madam, I don't remember because my urologist had written, so I don't have the knowledge what dose he gave. But the patient went well. One thing I just want to add, madam, as an oncologist, two of the patients with UTI recurrent, they were sent to me for examination, and when I looked in, the one had CSR wicks and one had a growth which was in the posterior fornix. Because when the speculum is kept, that growth is not seen. So sometimes recurrent UTI in certain patients, so definitely we have to rule out cancer because it is okay. And second thing is the pyridium we are using is very common because when we do radical hysterectomy, sometimes there is a leakage of urine. We used to do in our residency. Now it is really because now things of surgery has become very safe. But in those days, to rule out fistulas, then we used to give pyridium. Because if the urine is there, orange, so we can come to know there is a leakage of urine. So that way, you used to use double way to diagnose when there is pyridium to diagnose even when you are doing any surgery. Now, suppose you have done a laparoscopic hysterectomy, and if you want to see there is a leakage of urine, give a pyridium, put a gauze in a vagina.
So encourage pyridium sale so that it doesn't go out of market. It can be used by oncologists also. So that's what she's saying. And personally, I use the D-mannose by ordering 500 milligram D-mannose. I give 2 tablets DD. I get it from Amazon. I don't know about the sachet. And pyridium is, instead of side effect, you say side use of pyridium.
Yes.
The side use of pyridium. Now, Dr. Somlata from Vijayawada, what is the role of cranberry juice extract? All the supermarkets have cranberry juice, and it's nice to tell them drink cranberry juice, and your patient will be happy with you, and you are happy with your patient. Is it really worth it?
Yeah, actually, mostly studies say there is no role, ma'am, but in recurrent UTIs, we are using it, ma'am. Actually, it says like cranberry destroys the pili on the bacteria and helps in the clumping of bacteria and gets excreted. But in recurrent UTI cases, we are using, ma'am.
How are you using it? Juice or tablet or what?
Sachet along with D-mannose, the dose is like 120 milligrams. BD we are giving, ma'am, for 10 days.
So Cochrane is wrong, and this study is saying that it is good. 2021 study from some place. They said that it is good. But Cochrane review was saying it is bad, but personally Vijayawada is saying it's good. Vijayawada and the study is saying it is good, right?
Yeah.
Anybody else?
Mostly means like patients get.
I know Mumtaz is against cranberry juice. Anybody else from the panel is for cranberry juice?
Yeah, Dr. Bhavna, I also use cranberry and
Haruch
the
is for
recurrent
cranberry.
and repeated. Yeah, I use it.
Yeah. So two votes for cranberry juice. So it's some reviews for it, some reviews against it, but definitely practical experience, people say it is good. And she has given us the reason why. Now, this is something which I never heard of before I started reading for this topic. Anju Soni, can you please explain what is this methenamine hippurate?
Good
drug available in our country also. Basically, acts through, it's a bacteriostatic agent, and it acts by providing a formaldehyde from hexamine. And it is said that there is no acquired resistance from this drug. So Cochrane review says that it is very good in cases of recurrent UTI. And there are many studies which support this view of giving this drug, and it is available in many pharmaceuticals in our country also. I have used this in very few cases, and it is available in the form of syrup or tablets. Have very few side effects, especially nausea, vomiting, and diarrhea. But not in many cases. I have not much experience.
Which is the trade name of the drug that you used in Jaipur? And how costly is it?
Cost, I don't know, because you just write and patient goes and buys it. But yeah. The Mendelamine, Mandel, Mendelamine is the drug I'm using.
Okay.
There are others also available, but
Is it very costly?
I have no idea, because
you just write and
I just write and patient go and buy it.
And was it very effective in your practice?
Actually, I am working as a private practitioner, and most of the patients who come to me, are already been treated at many places with many drugs. So when
can you please discuss one patient for whom you gave this drug and it was effective? What was the history of that patient? What had you given before, and what
I have given this drug to an 83-year-old lady who used to have UTI at least 6 times a year, and she was very bad with taking medicines. I tried first nitrofurantoin, then she started taking nitrofurantoin. I don't know whether she was, because she used to live all alone with her husband and caretakers. She used to say that I am taking it. She's saying that I am taking the drug regularly. Of course, I used to coordinate with the servants, because she is kind of a family for us. But she used to have so many times urine infection, and she of course has a GSM symptoms also very high. So, but then I tried phosphomycin in her case also. That also was effective for a while, for some time, and now again none of the drugs are effective. Even when you do her cultures repeatedly, it says resistance. So I have started using this drug in her case, and I have seen that she gets benefited with this drug.
How many days you gave it to her?
I gave her for 1 week, then again got her cultured. If she has some kind of bacterial count going down, then I continue.
That is the way you realize that it is a good thing to do.
Yeah.
Bacterial count was going down.
Yes.
And what about the recurrence? Since she is a family friend, you would have known whether the recurrent UTI part went down.
Recurrence is there in her case, and I've been treating her for last good 20 years. And I don't know why the recurrence. Maybe her hygiene is, she's quite obese, elderly, hygiene is poor, or she's not able to.
At least for the time being, the bacteria came down.
Yeah, she has symptomatic relief. So, that is what is more important, when you treat a patient.
So that's the same way that D-mannose also bacterial count comes down. When pregnant ladies also, when they come and bacteria, the pus cells don't come down, and when you give D-mannose, it comes down to some extent. Otherwise, they are so worried.
Symptomatic relief is the most important part of, the therapy. Then the patient comes and tells you that I am feeling better. Then you say, okay, she's okay, so we can go ahead.
Okay. Jyoti Jaiswal, I know you don't use fluoroquinol at all, but some people like I use ofloxacin very regularly. You think my patient from Kerala will come to you, Jyoti, and what would have gone wrong? The Kerala patient, Trishur patient coming to Raipur. Jyoti Jaiswal, are you there? Jyoti Jaiswal?
Madam, can you listen to me?
Now we can hear you.
Okay. So, madam, basically, it's not like that we were not using fluoroquinolones earlier.
Thank God. I thought like nobody's even heard of fluoroquinolones, the way all of you were saying nitrofurantoin.
No, madam. Actually, at present, it is our first choice for the simple UTIs, not for the complicated UTIs also, nitrofurantoin. But fluoroquinolones can be used in a complicated UTIs as well. And earlier it was very frequently used in all kind of UTIs. And what you were discussing about the self-medication. So whenever you ask the patient if she has took the self-medication, it will be some kind of fluoroquinolone only. They will never come with the nitrofurantoin. But
so what happens in all old people? They are taking fluoroquinolone. Will you give it to old people?
No, ma'am. Especially for the kids and for the old people. Nowadays, even earlier, the people were used to giving the ciprofloxacin even in the pregnant and lactating women.
Oh,
but
no,
nowadays,
that
it
is
is
bad.
basically written that it should not be given to the lactating women and especially the elderly people because of the lot of tendinopathies, neuropathies, and lot of side effects which we were not understanding earlier. Lot of studies came down, so now everybody is aware of that. We should not give it here and there. Earlier we used to give right and left, either ofloxacin or norfloxacin or ciprofloxacin itself.
So all these 40 years plus gynecologists, 35 years plus experienced gynecologists, if anybody gets urinary tract infection, don't take fluoroquinolones, right?
Yes, bilkul. I'm along with you with this. Everybody, even I was giving fluoroquinolones, but since like last 4-5 years, we used
Anju,
to
you
give
want to keep talking? Say something.
And also
Hello.
the cotrimoxazole is a very good option.
Aha. Cotrimoxazole zindabad. Bolo.
So nowadays in gynec patients we give cotrimoxazole, and in obstetric patient we used to give nitrofurantoin.
Okay.
Recurrent UTI is a very debilitating and very bad condition. It affects the quality of life. So it's my practice that I regularly get the urine culture done regularly. And
That
what
everybody
I have seen
does.
clinically, what I have observed clinically, that quinolones are in most of the cases nowadays are resistant.
Yes.
So I don't give them these drugs until and unless they are effective and no other drug is available.
Okay.
Because sometimes even nitrofurantoin is coming as resistant nowadays.
Yes.
The way everybody is going to jump onto nitrofurantoin, that will become resistant in no time now.
Yes, I have seen cases. That is why I said in my practice, trimethoprim has come to be effective, and when it is effective.
So next year, next IAS president will have weekly webinar. Everybody will say trimethoprim because nitrofurantoin will become resistant by then. No?
Yeah.
Yes. The cephalosporins, even the cefuroxime is resistant nowadays.
FDA also has said now that it is not to be used as first line treatment. So we have to follow FDA guidelines and not use.
So cephalexin now slowly Jyoti is from behind from Raipur. She's saying no cephalexin. Okay, Bipasa.
Yes.
So 85-year-old patient from Anju's hometown relative. She says it's all because she's obese and she's not right. What went wrong with Anju's patient?
Actually, drinking lots of water. And nowadays, elderly, old people, or senior people, not old, they are afraid of taking lots of water even after, they don't take much tea after sunset. I have seen that because they have to look for washroom. This is not true. Yes, they should be encouraged to drink lots of water. And another habit is that wiping from front to back. That is very important. Otherwise, these infections around anus may come towards, urethra. So that is a good thing, and they, if possible, they should carry some sanitizer sort of thing, spray, which are available now for spraying on the seat cover if they have to use public washroom for commode.
That's a very good tip that you have given. Sanitizers on the seat cover.
Yes. And one thing is nowadays people use Western style, this commode. And I have seen my grandmothers, great-grandmothers, they used to use Indian toilets, and they were in the habit of squatting. And if sometimes for new problem they couldn't squat, they used to stand like this. And
but they never got urinary infection.
Yes, and this Western style. This commode, using commode is now I mean, everyone
Okay.
uses it and
Okay.
using
Okay.
this in
The
public.
way out is to use sanitizers. Fine.
Yes. And another thing is that nail. Elderly people, they don't look after their nail. Cutting nail regularly is a very important thing that should be taken care of.
Okay. Otherwise, when you clean your anus, the
Yes, from
infection
front to
remains
back,
inside
always
the
from
nail.
front to back. Yes.
Okay.
Even after
Okay. After Bipasa, anybody else wants to say anything on this?
Yes, madam. I want to add one
every
point.
time.
Madam.
Yes.
Madam, can I add one point?
Yeah. Who is adding?
Jyoti.
Okay, Jyoti, bolo.
Madam, one more point I have read somewhere that the style when we sit over the commode, like sometimes the leaning backward is a bad posture when you sit on a commode. A good posture for decreased chances of the UTI is leaning forward when one person is sitting on the commode is also helpful for the.
Okay, that's a good
It's
point.
like a
Anju?
question mark, like a question mark. I advise my patients, if you have to use toilets elsewhere, you try to sit like a question mark.
Very good. Okay, Anju, you want to say anything more?
After urination, most of the women don't wash and dry themselves. So
Yeah.
you keep a tissue in your bag and wash yourself well after urination. That will clean
Otherwise,
out
even fungal infection can come if there is moisture.
yeah.
Okay.
So washing the urine and then drying it up is very essential part of
preventing UTI. So that will
Yes,
close down.
I want to add one thing, madam.
Please, who is adding?
Yeah, Anjana. Madam, there is
Anjana?
yes.
Anjana,
Madam,
tell me.
There is a pee buddy which is available now where you can stand and you can urinate like a man. It's a pee buddy instrument. It is available. It is available on Amazon. Amazon. Pee buddy. It is a small pee buddy. It is like a cone type. You just put it near your. You stand. You put it below your vulva and urinate. The urine will directly go. It is like a cone. So pee buddy is
you don't have to sit.
You don't have to sit. You can urinate anywhere. In even bad bathrooms you can use. So I recommend my patients who don't want to, especially the corporate girls, they don't go. This is very common. UTI is very common in them and they don't want to go to washrooms. So they don't drink water. So I prescribe them pre-body. It is available very nicely in the Amazon. One packet.
PRE or FREE?
P-buddy, madam. P-double-E-E-D-double-E-E-Y. I'll put in the group.
The word P. Okay.
P-buddy.
Very nice tip that you have given us.
Very much like the male voiding urine. It is
It is cone. Even plastics are available, madam. If old people they cannot move around, so that plastic washable is also available.
Okay,
These
so
are
very nice.
wooden. This is a wooden. You can use and you can throw it. Use and
so
throw.
then the recurrent UTI will decrease. We can even use it in our pregnant patients who are having this problem.
Yes.
Yes. Who cannot sit? Who cannot have? There is no Western bathroom. You cannot sit. People who have gone knee replacement, they cannot sit down, madam. And whenever they are traveling, P-buddy is very good for them.
Okay, good. That's very good tips that we have got using sanitizers on the ship. Okay, yes, Anju.
Stools available. There are steppers available which you can put your feet when you are peeing or you are going for toilet. Jyoti, you had recommended about the posture, So there are no steps available which you can adjust with your height of feet, and that is very good for you.
Okay. Now we'll go on to the next topic. After the end of the panel, maybe we can still keep on talking of all these things. Otherwise, the next speakers won't be able to talk. Mumtaz, role of probiotics. Now, Anju was about to talk about all before itself. So I thought Mumtaz should talk because I've kept a question for her. Mumtaz, probiotics. Anju's question on probiotics.
Yes, ma'am. It is actually the natural protection. We were talking about the lack of hygiene, the cleaning methods and all that. But we have a natural protective mechanism in our body that is lactobacillus, which prevents infection. And when there is loss of lactobacillus, this predisposes to urinary infection, that is intracoital colonization will be there in the vagina. From the vagina, it is very easy to access the urethra and the bladder. So when we give prebiotic, it is like it prevents, it produces hydrogen peroxide like the natural lactobacillus, and that is bactericidal. And it also prevents the attachment of the bacillate to the epithelium, there is an anti-inflammatory response produced by lactobacillus. But it is not a substitute for antibiotics. But maybe in cases where there is where we want to use them for in patients with recurrence, they have found that the recurrence is less when we give them this probiotics after treating with antibiotics. We have to initially treat them. It is never a substitute.
Can you give along with antibiotic, because these probiotics will compete with the antibiotic?
Definitely we can give along with antibiotic, but we need to continue the treatment for a few more days or weeks or months, even after we stop the antibiotic treatment. So that definitely reduces the rate of or the frequency of recurrence, even in high-risk patients. And we have two routes. We can either use oral probiotic or vaginal probiotic. As we can imagine, vaginal probiotic would be better, but patient compliance is a very important aspect in this condition, this situation, where we need to give them for a prolonged period of time. So in
Mumtaz, is it available in Kerala or Perindalmanna, this vaginal probiotic?
Vaginal probiotic, I don't have any experience. I'm using.
It's not available to us that much, no?
Maybe it is not available, but oral probiotic, they say, is more compliant. Studies have shown good effect with oral probiotics because the compliance was better.
So how, which one to choose? How all these companies come and tell you probiotic. Do you have any guideline what to use, or anyone will do?
No, actually the dose is there. If that much dose is available in the probiotic, maybe that is good enough.
Okay, so we do not have standard doses for the which one
10
to
raised
use.
to 8 to 10 raised to 10 colony forming unit should be there in the probiotic that we are using.
So you have to put on your specs. You take a micro magnifying glass and you have to actually check 10 raised to 8 and 10 raised to 10.
Yes.
Then only you should prescribe.
Yes, ma'am. And the dose is BD usually.
So when the rep will come and give you, you take his, what is that? Whatever laptop or whatever they show, and then you check if there is 10 raised to 8 or 10 raised to 10, right?
Yes, ma'am. We have to.
Madam, I have one query here.
Yeah.
Can I ask?
Yes.
Madam, I have heard that for the local purposes, the oral probiotics are not very well worked. And the local probiotics are well worked, whether it is a vaginal infections or it is a like UTIs. So what is your say about that? And Vagilect pH, I think so it is available easily.
Anyway, it's not available. So then why worry about it,
Vagilect
Jyoti?
pH is available and it is a vaginal tablet.
It's available in Raipur.
Yes, it is
Okay, so
available.
Jyoti Jaiswal says that vaginal is better. Please write to her. If it's not available in your cities, she will send the sample from Raipur and it is better for your patient, right?
Of course, ma'am. Thank you.
Yeah. Okay. She is the joint secretary. She has to do something for IMS. So anybody in this webinar wants vaginal probiotics, they will write to the joint secretary. She will give the address of the person and send it. And she says it's better. So this is a take-home message that we two of us are giving. Now, Madam Bhavna said, we heard of intravesical lignocaine from our Mita's daughter Tanvir. What do you think about intravesical antibiotic for recurrent UTI?
Yes.
Madam.
It is used especially in an elderly female when the levels of estrogen keep on decreasing. The bladder musculature, the trigone of the bladder, they undergo atrophy, and the bladder wall also undergoes fibrosis. Post-voidal urine capacity increases, retention is more. So in such cases, there is chances of recurrent UTI. And in such cases, if we give intravesical antibiotic like gentamicin, we can give about 40 to 80 milligram in intravesical and keep it for few hours, or you can keep it overnight. This gentamicin in the bladder, then the chances of getting the episodes of UTI repeated decreases. And studies have shown that it decreases, the episodes have come down tremendously. Suppose a woman was getting about 4 to 5 episodes of repeated UTI, it has come down to 1. Not only that, even the resistance to the pathogens have decreased. Studies have shown that it decreases, the resistance decreases right from 78% to just mere 23% resistance in the bacteria. And the other advantage of using intravesical antibiotic like gentamicin is that it is not systemically, there is no absorption of it. So the side effects.
That's a very good thing. No side effect.
Yes, it remains in intravesical. The action is only limited to the bladder. So that is very good because you don't have systemic adverse effects of gentamicin.
The only problem is how to give it intravesically overnight and all that. Which gynecologist will work at night to put it intravesically at night? That is a practical thing. I think we'll have to admit them and do it. No, I think. Or that is the only problem. But it is working well, and maybe we have to work out the logistics and try this novel method out. At least in bedridden patients, we can try it out, I think.
Yes. Indoor patients you can give, or bedridden patients, or both the operative patients, they are getting this repeated infection, we can try. It gives.
Or when they come to OPD, we can put a little bit and we wait in the waiting area for some time. Things like that, no?
Yeah, even
all
1 to 2
prolonged
hours.
catheterization can be, patient on prolonged catheterization, this can be done, madam.
Yeah. So maybe that logistics we have to work out. But putting it overnight, maybe, I don't know. No, we have to
yeah, we do
try,
not have much of experience of this.
Yeah, but then we should learn all these things. Now, without side effects, we can give all this and we put it in this thing and make them sit outside and they are waiting for the ENT specialist. They will always have multiple problems, no? One person will see the ortho, one person will see something else, or wait, show the child somewhere else. In that time, it will act, I think, no? By the time they sit in the car and reach home, it will act. So,
and how can we put it for overnight, ma'am? 1 hour we can clamp the catheter and keep it inside. But overnight, won't the patient?
Yeah, who will insert it overnight? That is a question mark. But those study people, when they conduct a study, probably they are doing it. No, we are not conducting a study, but knowledge is important. We have to vary it and incorporate it into our practice.
1 hour looks fine. 1 hour looks fine.
Yeah.
No, we can keep it for few hours. See, no, not necessary overnight, but we can keep it for about 2 to 3 hours. In the OPD, we can ask her, and then we clamp the catheter, and then we can release it. So that would suffice, I suppose.
Then nothing is working, and people are coming back and back and back and back. Maybe we should try everything. No, that is there. This is just another opening out that we are doing. Madam Ranu Patni, please. How do you differentiate between our patient and our Meeta Singh's, Tanvir's patient? Patient is dysuria and urgency, recurrent UTI, and symptom relief will also require, relieving other things. How do you know the difference between the two? Ranu, madam?
Actually, if the symptoms are persistent, even when the urinary tract infection has got relieved with antibiotics, then we have to look for other causes like whatever Tanveer has said, like interstitial cystitis or bladder syndrome, the overactive bladder, etc.
One is clinically you give antibiotic. If it is responding, it is UTI.
Yeah.
If it is not
so
responding.
Actually, I would like to share. Recently, I had an unmarried girl who presented with persistent symptoms in spite of the UTI having been treated. So then we found that she had a large ovarian mass. So at times you have to have not only medical conditions like diabetes and other things, but we should be on the lookout for other causes like some kind of obstruction or some
You have to get an ultrasound done for everybody, even if they are coming from urinary problems.
Yeah.
What did you do then for that patient?
And another thing here, hello Shobna.
Yeah, Ranu, what did you do for the patient?
We had to operate her. She had a huge mass, ovarian mass.
Then she was relieved.
Definitely. Her symptoms vanished after that. She was an unmarried girl, so probably no one suspected. She came to me with after having gone to many people actually. Another thing was we were talking about Peabody, which is a very good thing which Anjana told us. There are disposable toilet seats also available nowadays, which can be used by people if they cannot find a Peabody or can carry a Peabody. So you can use disposable toilet seats also.
Okay.
So that is another
Apart
thing
from
that I
that, one
wanted
more
to say.
thing that I found was that the presence of irritative voiding symptoms between the perceived episodes. You know,
Yeah.
that is also very important, that the patient is having a problem every day. In between. Then also you have to think something is wrong, something is wrong.
Yeah, so then
So that is very
non-infective causes have to be evaluated then, of course.
Yeah, when there is persistence of symptoms in between the attacks, that also you have to check. Right?
Right.
So now, Dr. Anjana, Jai Hind, Modi ji ka land se aap aa rahe ho. What are the Indian guidelines?
Madam, you already put a chart or recording.
Yeah, but then, I mean, we are closing the session, so we have to know Jai Hind, what is the India guidelines?
Madam, acute uncomplicated cysts, you have already put now the drug of choice is nitrofurantoin, 100 milligram BT for 7 days.
So Indian government is going with all the panelists.
Yes.
India government is going with all the panelists who said
Yes.
nitrofurantoin and cotrimoxazole.
Madam, you have sent the slide, so everybody is speaking nitrofurantoin.
No, but we are not. That is the reason why they are not honest actually. Okay.
And ciprofloxacin, acute uncomplicated pyelonephritis, you already said nitrofurantoin is not effective, and the drug of choice remains amikacin and or gentamicin, and the other alternative treatment you already written, Madam. So these are the choice. I think so. These are the choice which are being followed most of the doctors everywhere.
Okay, so that is for a closing remark from Ahmedabad, from a person whose throat is just recovering. So to sum up the panel today, you can have vaginal estrogens you can have D-manos, you can have methenamine, you can have artificial toilets, P-buddies, you can have sanitizers and antibiotics, nitrofurantoin and thiamidoprin. Jai Hind has told that. Cephalexin from Raipur, phosphomycin, 2 attacks, and then we have also probiotics, vaginal probiotic if you are from Raipur. If you are from other parts of India, you write to Raipur, otherwise you give oral probiotics. Vitamin C, cranberry juice is good in Vijayawada, not good in Cochrane review, but cranberry juice is good in Bharuch also. And the rest of India, so many people are using cranberry juice also. So thank you so much for this very active panel. Everybody gave inputs and I had very good. Now the floor is open for discussion.
One thing.
Yes, yes.
Can I add one thing? Yeah, actually, I have seen that these patients have a lot of vulval dystrophy. So moisturizers, vaginal moisturizers, they help, and hot sheets baths also helps them a lot.
But what is the difference between why not give estrogen instead of moisturizers? Why Anju moisturizers? Is the estrogen
See, you are giving estrogen only twice a week.
Okay, so in between you give moisturizers.
So that really helps. I have seen it practically.
Okay, that's a very good tip. So learn from each other. That's good.
And hot sheet baths also really help them.
Anybody else wants to give in their inputs from their own practice, please go ahead.
What I do, Shavna, when patient comes with this thing supposed to be UTI, I advise them urine culture sensitivity, and for the first day,
all of us do
before the report comes, if they can afford, I advise them phosphomycin. So they can get
even all of us are doing it.
Many of us accordingly.
Very good. Okay. Anybody from the audience wants to say something, please, other than the panelists? Yes, Jyoti.
Changing of antibiotic, like if we know the trend, if we know the trend that what kind of antibiotics they were taking earlier, like one was taking nitrofurantoin earlier, but not at present and not getting relief, then we can understand that in this case cotrimoxazole will do better.
Okay,
Or
okay, you change over.
Change over.
Now, Dr. Verma, you want to say something, Dr. Verma?
Just a practical tip I want to give, and I have tried in many of my patients. In patients having recurrent UTI, having 5 to 6 episodes of UTI in a year, just I am asking them to wash the private parts with some soap after coitus. This will help in preventing the recurrent UTI in such patients.
Instead of just water, you want to use soap in
No,
addition.
yes, ma'am. I want to use soap, and usually I used to give them Dettol liquid hand wash to wash private parts.
My God, that's a bit dangerous. Because
No, it
once in
should
my
not be
patient, one patient has come with lot of reactions
No, ma'am,
because
it is
they didn't
only
wash
liquid
it.
hand wash.
It
It
should
is
not
only
be
hand
given.
wash, ma'am.
Why not
Madam, I will differ here. Madam, I will differ here.
I differ.
differ
I
here.
myself also differ.
Because the most use, much of use of the soaps or some any other chemical thing is actually decreasing the real vaginal and flora, nearby vaginal flora.
It
So
increases
I will,
alkalinity, whereas you need
Yes.
acidity there. We are using lactobacillus to increase acidity, and you're using soap to increase alkalinity. I don't know how far, but from her practical experience, she says it's useful. So we have to listen to each other. Keep
Yes,
our mind.
ma'am, I am
and
telling
for some good patients who are having the hair
it
dryer
it
in
has to
their
be used
washroom,
only after
they
contact.
can
Who is
use
talking?
after.
Please unmute yourself, raise your hands, and tell you who is speaking. We can't hear you. Who's speaking?
Jyoti.
Okay, ज्योति ज्योति का तो सुन लिया और कोई बोलने वाले थे नहीं तो फिर ज्योति बोलो.
टिप है मैडम, एक टिप है इसलिए. And it is there one who is having the hair dryer in the washroom can use after washing with the normal water, can use the dryer for drying the private part. This tip I has got from Maninder madam that really works well.
Okay, okay. So anybody else? Sushila, you want to say something? Anybody from Vijayawada? It's your show today. Riddhi Shukla from Vijayawada. Sushila,
Yes.
anybody wants to contribute?
Yeah, I usually ask my patient, we do ask them to use condoms for patients with recurrent UTI and do ask for a sexual history. If they are into more of a oral sex or something, then I usually ask them to avoid that.
Okay, so but the spermicides on the condoms may also be causing allergy. That is one theory that is put up in the
Condoms
chapters.
should not be used.
Yeah, because they have spermicides and there may be reactions to that. So we don't know whether we can, all of us agree with you because the theory is saying that and we have never tried it out, so we don't know.
Yeah,
So,
and
Manoj, you want to say something? Urogynecology head.
I've been listening to you, and it has been a really a wonderful panel, and really thank you so much for it.
and to change the moist clothes in case of like they are wet.
Oh yes.
At least per day.
Yeah, wear fresh clothes if the underclothes become moist.
And cotton clothes.
Okay, fine. So, if nobody else has got anything to say,
Ma'am, just I want to say what I have tried in many patients who complains of postcoital UTI. Just suffixing 500 mg. Ceftriaxone 500 mg instead after the coitus is very helpful for those patients.
okay. So whatever Dr. Bhavna said about postcoital antibiotic has been actually been used by people. That 500 milligram of ceftriaxone postcoitally was very useful. But then when we presented this in Calicut, one very naughty gynecologist said, "Abhi तीन बार करेगा तो क्या करेगा? तीन बार खाओगे गोली?" ऐसा पूछ रहा है. I don't encourage who will do 3 times sex.
I want to say one thing.
High-end drug. Cefuroxime is a very high-end drug, and it should be kept reserved for the severe UTIs. For the postcoital UTIs, simple 125 or 250 milligram of ciprofloxacin is a very good drug, and I have tried it in many of my patients who had specifically postcoital complaint every time. So when they used to take
either ciprofloxacin from Raipur,
I want to add. During lifestyle modification, I forgot one very important point which I always advise to my patients, not to put the undergarments of the family members in washing machine. I always give them this advice. Undergarments should be hand washed separately, and this may avoid cross infection in the family members.
Okay, okay.
And also tight clothes.
Yes.
Where they prevent the, like they cause perspiration.
Okay. Okay. Fine. So anybody else wants to say something?
Now something from Shobna madam.
No, I have been asking and answering everything, and I let me tell you, to be honest, I use ofloxacin every day for my patients with UTI. Maybe now I will stop using it after 65. Nitrofurantoin is for me second line of treatment because I need some second line now. If I make everybody nitrofurantoin resistant populate, trimethoprim IS I use in my practice and D-manos for patients who are resistant. That is my take on it. And or now maybe I will learn to use this P-Buddy, intravesical, gentamicin, methenamine. अभी सबका नाम सब सुन के Amazon से खरीद के रखना पड़ेगा. We will learn all that and we will not forget after this panel. So thank you all so much, and all of you
Thank you,
have
Shobna ma'am, for such a wonderful webinar. Thanks a lot. And I'll request Sushila ma'am to kindly give vote of thanks. And thanks, Dr. Sushila, for all your efforts, and Dr. Riddhi. Thank you so much for the first successful webinar of Urogynec under Shobna ma'am's tenure.
I hope that it continues in September 9.
Yes, ma'am.
Yeah, it has been an excellent panel with a friendly moderator to say. So on behalf of Vijayawada Menopause Society, I thank our president, Dr. Shobana Mohandas, for giving the opportunity, and Dr. Manoj Chelani to conduct with us the first Urogynec webinar. And the chief guest, Dr. Hara Patnaik, conveners, Dr. Lakshmi Shrikande, and our chairpersons, Dr. Rama Madam and Dr. Shailaja, and speakers, Dr. Gayatri and Dr. Tanveer, and our panelists, Dr. Mumtaz, Dr. Bipasa, Dr. Jyoti, Dr. Anjana, Dr. Somlata, Dr. Anju Soni. Thank you so much. It has been a wonderful program, and looking forward once again to have such a sort of program. And I request Dr. Lakshmi Shrikande Madam, as a part of education committee, to have one more webinar, one more topic with us. And I thank all the delegates who have joined in, and also all the doctors for their inputs. We have learned so much, and then we continue to learn from Indian Menopause Society and our members. Thank you so much. Good night.
It was a very good, successful webinar. We had around 88 to 90 delegates who have logged in.
Yes,
so thank you all for making it a grand success.
Because we learn from each other so much. Everyone's practices. Everybody is seeing recurrent UTI, and I really learned from everyone. It was really nice. Thank you all panelists. Really, you made my day by giving your experiences instead of just theory. So that was very important. Thank you so much.
Very practical, and then the tips also, and the newer innovations have been discussed. So,
yeah.
Thank you so much.
I think we have to call it a day. All good things come to an end. So till next week, bye-bye. Next week is with Guwahati. So till then, bye and take care and have a good day. Thank you. Bye.
Thank you, Shobna ma'am. Hope like many of us will be there in Chennai next weekend.
Yeah. Waiting to meet you all in Chennai coming week. Okay, bye.
Bye, ma'am. Thank you.
Thank you so much also. We are closing here for today. Thank you. Good night.